One of the decisions we took was to not require roll-in cases. So everybody's first case was in the trial, right? We had almost every discipline that does intervention on CLTI patients in the trial. So different kinds of operators from different disciplines enrolling. And so there were those, when you see 99%, technical success out of that, I mean, that was tremendously reassuring for us. So it's been a big success from that point, but we weren't sure how it would go when we,
Well, the
when
other
we began.
thing, the other thing, Dan, that we shouldn't fail to mention is the wound healing. It's incredible. At 6 months, we have had a quarter of the patients had their wound completely healed. Remember, these are patients that were Rutherford 6, Rutherford 5, advanced wounds. And about 50% of the patients were in the healing process, clean clothes with significantly smaller wound size, having undergone minor amputation. So I think that's another important endpoint, and I don't know if you agree, that is extremely important for this population.
I think that, and the other thing I think that's incredibly important is that we're moving patients. If you look at Rutherford categorization, we're moving patients from Rutherford 5 to Rutherford 0. I mean, these are patients who have no wounds, have no pain, and are walking on their limb without problems. I mean, I look at the change in Rutherford classification, and that to me is almost astounding.
I think about it all the time, and I completely agree. We've established the floor of where the outcomes are. When you start with a new therapy, very similar to what was done in TAVR, or it was done with AAA, with non-surgical candidates, you establish that you can make this technique and technology and therapy, because it's a mix of all three things, a success in those worst of the worst patient. You've established the floor of what you can do, because you don't have much experience. The technology is in its, earlier generations. The physicians have very little experience themselves with managing the patients afterwards. And you're in the worst patients you're ever going to treat. Yeah. So where can we go from there? I mean, if we continue to do our job and evolve in the therapy and the technology, physicians continue to learn how to treat patients better, and we can really do something amazing here. And we're already pretty excited about what we see, but the next phase can be even better.
Yeah.